Will there be true, false, and fill in the blanks?
This will be all multiple choice. I have written, I think, half of my exam questions. I will say, even though I just answered that it'll be multiple choice, some of those multiple choices do kind of have blanks, and then I've got multiple choice answers to fill in that blank. So it'd be like blank is blah, 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 blah. And then I kind of have that multiple choice below. So it's almost like a fill in the blank, but you're given multiple choices, if that makes sense. I do in the questions I've written, I have some of the all of the above, none of the above types of questions. So that is a question type that I have written thus far, yes. And again, feel free to unmic and ask a question. And then if you feel more comfortable throwing your question up in the chat, right now while we're discussing this or while I'm discussing the material, feel free to do that. Again, that's kind of a nice seamless way to integrate your questions into whatever we're discussing. So hopefully I'm answering from both places. So I'll again pause for a second to see if anybody has any other questions. Okay. So I will tell you, as if I'm providing you a study guide, I don't want that study guide to mislead you. I want that to be useful for you in terms of you knowing where my questions will be coming from. So as I'm writing my questions, I'll tell you right now that I'm going back and forth with that study guide and actually just making sure that there's a really strong correlation between what's presented on that study guide to you and the types of questions that I'm asking on the exam. I'm kind of following suit. And not asking super specific questions, trying to keep it pretty broad, general concepts, unless there's a specific drug that we talked extensively about, which we'll see kind of today that there are, we'll see kind of a laundry list of general anesthetics that we'll talk about some characteristics and why they're selected. And then not today, but probably tomorrow, we'll start going through kind of our laundry list of local anesthetics and just kind of talking about some of the advantages and disadvantages to the uses of each. So I would say, answering questions that are popping up in the chat, I would say it's probably going to be a mix of like general, like, I guess I kind of answered that question just now where there are some general questions, but again, if we've talked specifically about a drug, if a drug has an entire slide dedicated to it, I feel like that's kind of open for a possible question, just because if it's taking up an entire slide, we're obviously going through, the chemistry, possibly chemistry, the side effects, the toxicity. We're talking pretty extensively, probably spending at least a minute or two of class time discussing that drug. So if you see a drug that has an entire slide kind of dedicated to it, I'd say that's pretty open field for possibly being asked about it on an exam. Yes, so somebody else may ask the point about the local anesthetics and if there will be an update to the study guide. Yes, so as I wrap up material tomorrow, there will be an update to that. I guess we have the advantage of wrapping up the material tomorrow, then you have basically all of Wednesday evening, Thursday, and then Friday morning to study it. So I will be trying to update that as soon as we finish our material on Wednesday, just kind of see how far we get and kind of what's emphasized during that time. Okay, any other questions or concerns at this time before I move on into material? Just want to again make sure we get these questions answered, because I understand exams can be a source of anxiety, but as Keith always tries to say, don't stress out about them too much, right? Okay. Okay, so I'm going to go ahead and start kind of kicking off on our material again here. I'm keeping my chat window open in front of me, so if you do have any questions as I'm lecturing, please feel free to stop me, or I mean, even if it is like a literal like slow down, not going to take offense to it. I totally understand why you might be writing that in the message. Okay, so we have covered intro to CNS, we've covered alcohols, and we've discussed general anesthetics. We got to basically the end of the chapters on general anesthetics, and this is kind of, again, where the laundry list of drugs kind of comes into play. As a pharmacology class, I think it's appropriate that we discuss some of these drugs and exactly how they're being applied. They're great examples of general anesthetics, and we're going to talk about the, the pluses and minuses, when one might be advantageous to use over another, and as side effects generally kind of play a role in that. So I'm pulling my lectures directly from Goodman and Gilman and Kassung. That's where all of my well, a majority of my figures are coming from there. So if at any point during the lecture you feel like you need further explanation or what have you, please do go to the textbook, because I feel like they're great resources and can essentially clarify whatever I'm going through in class. So I don't have a roadmap here. We will go see a roadmap at the beginning of the local anesthetics portion of this lecture. So we're just going to continue, like I said, going through our laundry list of general anesthetics. So these are IV anesthetics that we're kind of kicking off talking about here. The first one that we'll be discussing are barbiturates. Specifically in this slide, we're talking about thiopentanol and methotrexate, which is the focus of this particular slide of discussion. Barbiturates are going to activate those GABA A receptors. You're going to see that this is a very common site of action for the general anesthetics. Again, when you have a general anesthetic, there are these 5 characteristics. Wink, wink, nudge, nudge, maybe know the 5 characteristics that an anesthetic is supposed to be achieving. Maybe check out that slide. It's in the previous lectures. In terms of the pharmacokinetics, it does undergo hepatic metabolism and increases porphyrins. Those are going to be a metabolite or an enzyme that's responsible for heme, the generation of heme, and you can actually have individuals who have polyphoria. And so in the case of if you are treating someone with polyphoria, barbiturates can kind of exacerbate that. So you just want to make sure that you know that part of the patient history. If they are suffering from polyphoria, you won't necessarily want to exacerbate that with barbiturates. And kind of expanding down the pharmacokinetics, methotrexate has a shorter elimination. Thiopentanol has a larger plasma clearance. If administered through repeated bolus injections, recovery will be prolonged using these barbiturates. What's interesting about barbiturates is that they can be used in low dose or high dose situations, essentially, and those dosages are going to directly affect kind of the physiological response that you have. So you can treat at a very low dose, have minimal effects on EEG readings, or you can treat at a very high dose again, and that's going to significantly silence the brain and EEG recordings. They also are vasoconstrictors, and again, that's an important kind of consideration to take when you're thinking about the use of a barbiturate with specific types of patients. Does decrease systemic blood pressure, can act as a respiratory depressant. So if you have an individual who is respiratorily compromised, a barbiturate maybe isn't your first choice. And again, because we are teaching a pharmacology class and you are future pharmacists, I think it's always interesting to kind of check out dosages. Again, I don't necessarily need you to memorize these dosages. It's just more of a relative, it's interesting to kind of compare and contrast the relative dosages between these IV general anesthetics. So again, here you can see the general dosages for thiopentanol and methotrexate. Okay, any questions about barbiturates before we move on? Okay.
Katie, I have a question.
You actually made me jump a little bit, yes?
Sorry. So the barbiturates, you said that it's dose dependent, so someone could actually go under anesthesia with them.
Yeah.
But then I know they're kind of similar to like benzodiazepines, like they have the same target. So are you using that for anesthesia or sedation or both?
You can use them for both. It just kind of depends again on that dosage that you're giving. Because they do have the same target of action, benzodiazepines are often used at the beginning. You might use a different general anesthetic later on, but because of the positive side effects and the fact that it kind of decreases, it's an anxiolytic and things like that, I think generally benzodiazepines are maybe used at the beginning of folks going under, and then sometimes they'll switch over to other IV anesthetics later. But I see Keith, and so I'm guessing he has something to contribute to this conversation.
Just going back to thiopental, very definitely you can induce anesthesia with that agent alone. The thing about it is it's so lipid soluble, it rushes into the brain within just a few seconds, and then it rushes back out. And so if you don't keep applying thiopental, the individual will lose the anesthetic state unless you follow it with some other anesthetic agent. For many, many years, thiopental was the most commonly utilized inducing agent. the beginnings of anesthesia were started with halopental, and then another agent such as halothane or something like that followed in behind it. Now propofol has sort of taken over in that regard, and it's sort of the most common inducing agent available these days. But you can do the whole anesthetic regimen with something like halopental. It's just that it's a little bit difficult to do that because of its pharmacokinetics. So it's primarily used as an inducing agent. So anyway, I just thought I'd toss that in there a little bit, Katie. Thank you.
No, I think it's a great addition. And it's probably worth even going back and revisiting propofol and phosphoprofol. And again, those are kind of the main IV anesthetics that are being used now. Again, these other ones are probably used under slightly different circumstances in case there's some negative reaction to those other options. Does that answer your question, Sydney?
Yeah, thank you. That helped.
Okay. And that's a good, I guess, transition point into the benzodiazepines. Again, they share a similar molecular target. They're both going to be GABA agonists. And so midazolam, lorazepam, diazepam. Here you can see the FDA-approved benzodiazepines and their structures, and some in their more common names. You might know them as things like Klonopin and Valium. Their actions are terminated by the antagonist flumazenil. Again, this is going to be that GABA antagonist. So you're basically pharmacologically kind of bringing an individual out of anesthesia by the treatment of this antagonist. They are highly lipid, and so they're going to have that same effect that Dr. Parker just talked about, where you have them fastly reaching the brain and a rapid onset of action because of that. And midazolam has a slower effect than propofol and thiopental. Again, decreased cerebral blood flow, a potent anticonvulsant. Again, this is kind of another place where we'll probably discuss the benzodiazepines when we're talking about anti-seizure medications. Kind of pulling back from my experience at the Army, midazolam is probably is part of the treatment strategy for individuals who've been exposed to somatic to decrease the seizures that are essentially sustained post-exposure of these organophosphates. So again, that kind of overlaps with some of the previous material that we've talked about. But again, midazolam is one of the parts of that treatment strategy to decrease that seizures. And then also, it probably does have some highly sedative effects at those concentrations as well. What's interesting to note about the benzodiazepines is that there is a minimal depression of ventilation. So as I spoke about in the previous slide, if you do have a respiratorily compromised patient, taking into account the drug's effect on respiration is an important point to make. Severe respiratory depression occurs when administered with opioids, so it's always important to take into account those drug interactions. Some IV injection pain has been reported, but again, it's got some advantages. Things like it's got anxiolytic and sedative effects, make it a popular preoperative medication. So when we're talking about any of these IV and anesthesias, it's important to think about kind of how they can be used in comparison with one another. So again, the benzodiazepines share the common target with the barbiturates that we just talked about. Okay, etomidate, it has a hypnotic but not analgesic effect. There are some endocrine side effects. Similar to what we saw before with the previous two drugs, it does have a very rapid onset due to its lipophilicity, and does have a metabolism, pretty quick metabolism. It does act as a potent cerebral vasoconstrictor, so it does decrease intracranial pressure. So again, taking into account the type of patient that you're working with and what the patient's suffering is important when you're looking at these CNS effects. More EEG activity, so there's probably not as high level of sedation that we're seeing here. Minimal changes to cardiac output, less depressive respiratorily than barbiturates, but can be used as an alternative to propofol and barbiturates for a rapid IV analgesic. Again, because we are talking about pharmacology here, I do always like to include these dosages that are noted in the textbook. And then I've also included here just a structure as well as what the general therapeutic range that we see in the plasma concentration with the treatment. And so it gives you kind of a time course of sedation that you can see here. So it's, again, we don't talk about time of onset often with many of these other ones, but I thought this was, I found this figure and I just kind of appreciated that it showed that onset. Okay. So the next analgesic we'll talk about is ketamine, partially water soluble. It's interesting because the site of action here is going to be slightly different. So instead of interacting with the GABA receptor, you're actually inhibiting the NMDA receptor. Again, the molecular mechanism of learning memory is directly linked to the NMDA receptor, so it's not surprising that this would have an amnesia effect to it. It does have a rapid onset. It's metabolized in the liver by cytochrome P450. It's increased cerebral blood flow, but one of the side effects to this particular drug, and maybe the reason that it's not used as frequently, is because of these other side effects that it has to hallucinations, out-of-body experiences, increase in visual, tactile, auditory sensitivity. It's used recreationally, often called Special K. But it does increase systemic blood pressure. And so again, it's not clinically used a ton just because of these psychomimetic effects. And then you can see that there's a variety of ways in which it's administered. And then again, I'd like to include the dosage here. But yeah, again, I've kind of put together these slides so it's very easy for you to compare and contrast each one of these drugs. And I think putting them in the same structure allows you again to hopefully draw the distinctions between each one of them as you're kind of going through and studying them. And I see Keith's face, so I'm excited to hear what he has to say.
I won't take too long on this one, but I could, because ketamine is certainly one of the more interesting compounds out there. The parent substance in this class of agents is phencyclidine, or PCP. And that was first introduced back in the mid to late 1950s as sort of an alternative type of anesthesia. As you notice there, the terminology dissociative anesthetic is sometimes used, or sometimes even paradoxically, they're sometimes called the so-called stimulatory anesthetics, which isn't quite right. But do note down there about 3/4 of the way down, there's a difference in respiratory depression. So there's not as much cardiovascular and respiratory depression with ketamine and phencyclidine as there are with the other anesthetic agents. But this emergence phenomena, which is basically a hallucination, is particularly a problem with phencyclidine. And that's why it was pulled off the market, and sort of ketamine came in behind that back in, about the early 1970s or so. There's a news story in addition with respect to ketamine, and that's its really unanticipated use as an antidepressant agent. And we'll talk more about that when we're talking about depression later on in the semester. So I'll just hang that out there right now, because what we need to concentrate on at the moment is the anesthetic area. So ketamine is tremendous utilization in veterinary practice. It's also quite useful in the geriatric population or in infants, again, because it's less depressant than the other agents. Anyway, really, really fascinating stuff. And I'll stop with that right now, but we will be revisiting it again in another month or so.
Yeah, I think it's really interesting to think about just, again, the pharmacology behind these and their targets, and how there's just so many different effects that they can have. And I think the lead that you left off with, talking about it being used for an antidepressant, is really interesting. I think it's, like you said, a new field that's just being investigated now. Okay, so I just wanted to include this slide showing some of the current clinical practices. Again, just giving you both a generic name, what it's also available as. And again, I don't expect you to necessarily memorize a table like this. I think this is more just general FYI. If you're working on a case, or if you're working in a particular pharmacy and you see these names, hopefully that it starts to kind of ring some bells and you're like, oh, we did discuss this in pharmacology, or maybe you've seen these on the shelf in the past. Okay, so time, oh, my concept check has just disappeared here. Okay, so let's see, I don't know how much. Okay, so maybe I'll just read it to you. We'll just do an auditory concept check here real quick. Okay. So listen up. A 40-year-old woman is suffering from both appendicitis and COVID. Must have emergency surgery to avoid sepsis. What is the safest IV analgesic to use? So given those two kind of comorbid diseases she's suffering from currently, what would be the safest IV analgesic to use? So go ahead and given what you just saw in the previous slides, go ahead and private message me your answer. Hopefully this isn't like a super long thinker for you, but she's got appendicitis and COVID. So what IV? Okay, I've heard from about 6 of you. There's 40 of you, 2 of you here. Okay, I've had a few more folks pop up here. Okay, so I see there's kind of a split here, and I actually would say, given the discussion that we just had, I probably would I would agree with kind of the split that we have. Currently, we kind of have a split between benzodiazepines and ketamine, and I would say both of those would probably be appropriate. Just again, the reason for choosing one or the other of those would probably be because you have an individual who is in a respiratory distress. They're suffering from COVID, but they do need to be, essentially put under. And so both of those would probably be appropriate for this situation. Keith, would you agree with that?
Yeah, that sounds good to me, Katie.
Okay. So I just want to make sure you didn't have anything to add. So yes, benzos or ketamine probably would be the two drugs of choice there. Okay, so we're going to go ahead and that kind of completes the chapter on general anesthetics. And so we're going to switch our focus to local anesthetics. And the chapters for Goodman and Gilman that this correlates to chapter is chapter 22, Katzung is chapter 26. And I chose this picture because has anyone ever been this happy to get a shot in their mouth? I just thought it was a very humorous picture. And I was like, you've got to be kidding me here. And it almost doesn't even look like it's going into a gum. It looks like it's going into a tooth. And I'm just like, this is not real life. Okay, so let's go ahead and kind of, again, switch our focus from general anesthetics to more local anesthetics. Needles don't look nice either. No, I agree. Okay, so kind of how would you describe or define a local anesthetic? Is the loss of sensation to a focal region. You want it, it's just in a specific area. This is achieved by disrupting neural transmission. So we'll talk about all these anesthetics. They have a very kind of common target. Many of them are going to be targeting voltage-gated sodium channels, but we'll talk about that extensively in the following slides. In terms of the structure of local anesthetics, here you can kind of see the general structure here. You'll notice that many of them have a lipophilic group, this aromatic ring, an intermediate chain via ester or amide to an ionizable group. And that ionizable group, again, is going to be very important when we're talking about how it interacts with the receptor, how it passes through the membrane. And so that's kind of part of how this particular class of drugs really acts. But again, it's interesting to note the similarities and differences when we're looking at the chemistry of each one of these local anesthetics. Okay. Ooh. Why are my tables not showing up? Or my, okay. Not gonna, I will post the table that's associated here. I'm not quite sure where it has gone, but it's just basically comparing the potency as well as the duration of action of many of the anesthetics that we just saw. So I will update that, post that to Moodle, and then we can probably start off our discussion tomorrow with that, so you're not missing out on
Katie,
the information. Yes?
you might want to check the rest of your slides because there's one version of the slideshow on Moodle that is very blank.
Huh. Okay.
Yeah, and then there's another that's actually has things, but some of them don't.
Okay. Okay. So I'll go back and check the different versions of on Moodle. I actually thought, okay, well, that's my bad. Hopefully you're able to see the one that is populated, correct?
Yeah, I just found it.
Okay. Okay. So my apologies. I'll make sure that gets updated as soon as we wrap up class today. Okay, so again, kind of continuing this discussion of how chemistry is going to affect the function of these local anesthetics. So I talked about how there's this ionizable form of them. And so extracellularly, the anesthetics are in equilibrium between their charged and uncharged forms. And so you've got that constant equilibrium kind of passing back and forth. And so it's the charged cation penetrates the membrane poorly. So thus, in order to be able to penetrate, it has to be in its uncharged form. It passes through the membrane, and then once intracellular, it kind of again goes between that charged and uncharged form. So it's that charged form intracellularly that allows it to interact with the site of action, which again, I kind of alluded to the fact it's going to be those voltage gated sodium channels. And so again, it's kind of an interesting way in which these class of molecules is able to enter the cell by going between the charged and uncharged state, and then altering that once it gains access to the inside of the cell. It can also gain access more directly by diffusing laterally within the membrane through a hydrophobic pathway. But again, we'll talk specifically where it's interacting with that sodium channel once it has gained access to the inside of the cell. Does anybody have any questions about this particular slide or the chemistry of local anesthetics? Okay. Okay. So, you know, the issue that we're having here is that this is an earlier form of the presentation. So, I apologize if you don't mind pausing for just one moment. Keith, any history on local anesthetics? Okay. Okay. I apologize. That was a earlier version of the presentation. Okay. And I just saw something pop up in the chat. Okay. Okay. So yes, I apologize. Let me see if I can fix the Moodle issue really quickly here. Okay. There are, I think, 3 versions available. I don't want to take too much time out of class and click through all 3 to figure out which one is which, unfortunately. But one of them should be the correct one. I apologize. This is probably not the, let me see if I can just do a quick
On my
save.
screen, it was the last one.
On the screen, it was the last one that was complete.
Yeah, at least so far, yeah.
Okay. So I'm going to hide the other 2. Okay. Hopefully we're able to fix that pretty quickly. Okay. Technology. Okay. Okay. So yeah. So what I've done here, just to kind of reinforce this charged and uncharged state, was to show just different colors of the charged and uncharged state and kind of where they're going in the pathway, whether they've passed through the membrane or not. And so kind of running through the ADME of local anesthetics. Again, the administration is going to affect kind of the rest of the ADME kind of states of this. So your dosage, your site of injection, tissue binding, local tissue blood flow, the use of a vasoconstrictor. We're going to talk about how vasoconstrictors are often co-administered with local anesthetics. The physiochemical properties of the drug itself, particularly lipophilicity. When we talk about things that are more lipid, it's going to be more potent, longer duration of action, take longer to work, not surprisingly. When we talk about distribution, I thought I was being more funny when I put local. Obviously, that's a joke. There is some systemic effects of local anesthetics, so it does perfuse across other tissues. A quick rise time and exponential decay in very highly perfused and vascularized tissues, things like your brain and heart and your cardiovascular system, slower time course and less well perfused tissues, things like your musculature, for example, and your gut. The M, we're going to talk about the metabolism more so tomorrow morning in our discussion, but it is converted to the more water-soluble liver by P450 in the amide type, and I'll actually show you kind of the differences between the amide and the ester types, the structural differences, as well as a list of drugs that fall into those 2 categories. And then for the ester type, it's metabolized in the plasma by butyrylcholinesterase. And so when we talk about, again, these 2 mechanisms by which these local anesthetics are broken down, here with the ester type and the amide type, I'm giving you some examples of some drug names and kind of the relative time courses for their metabolism. Procaine and chloroprocaine are going to be metabolized in less than a minute. And then we'll talk about the amide type, so you can kind of see the laundry list there from fastest to slowest, giving you kind of an overall sense of how these drugs are overall metabolized and relative to one another. In terms of their elimination, they're excreted in the urine. So again, this is just kind of a very quick synopsis of the ADME of this. We will be kind of expanding on the metabolism tomorrow as part of our discussion.
So I have a question real quick. So you're saying the amide types last longer than the ester types?
They don't necessarily last longer. They're just metabolized in different ways.
Okay, because I was going to say, I would think the amides would go faster than the esters. So, okay, thank you.
Yeah, I didn't necessarily draw any direct correlations there. And some of these drugs are metabolized very quickly and they're very short acting. And yeah, so we can actually see some of those comparisons here. So this is just a nice table that outlines some of the amide local anesthetics, kind of their distribution, elimination, and so forth. So you're also looking at their clearance here. So it's just nice to kind of, again, get a relative understanding of how these drugs behave metabolically. Okay. Yes, Keith?
Oh, just a note on cocaine. Note that into the ester category also. And in fact, cocaine is sort of the parent local anesthetic. We often don't think of it in that way these days with its, tremendous CNS stimulatory properties. But cocaine is certainly a consideration, and that distinction between amide and ester is a really important one to make. So I'm glad you've emphasized that, Katie.
Yeah, and tomorrow, part of the lecture will be focused on just like that metabolism and actually looking at the structures as well as the list of the amides versus the esters. And so we'll be revisiting this again tomorrow, kind of to just reinforce that point. But yeah, we'll also be talking more extensively about cocaine. So today's just kind of a general introduction of the local anesthetics, and then tomorrow we'll probably get into that more like laundry list of each one of them and their characteristics, their side effects, their metabolism, and so forth. Okay, so in terms of the mechanism of action, I've alluded to several times that the target that we're looking at here is voltage-gated sodium channels. Again, it's not surprising that that's going to affect neurotransmission. And in the next slide, we'll actually kind of look at some figures that reflect that effect on neurotransmission. There are several different subtypes or categories of voltage-gated sodium channels here that you can see via the nomenclature. The alpha subunit is going to be pore forming, so there's a couple different subunits involved with the voltage-gated sodium channel. And so here we can see this wonderful figure that we've actually, I think, looked at before when we may have even visited this when we were talking about neurotransmission, looking at the voltage-gated sodium channel. So it's important to recognize you've got these 4 domains of the alpha subunit and then these 2 beta subunits that are involved. What's probably the most important, well, not the most important, but something of note are things that like this inactivation region. Again, this is going to be part of the site of interaction for some of these anesthetics. And then you can see other modulatory points intracellularly here, things like modulation by PKA and PKC, but again, this is not the site of action of the local anesthetics. And then you can see the voltage sensing S4 transmembrane segment. And again, these types of ion channels are going to sense voltage changes, open up, allow for the influx of sodium. This voltage-gated sodium channels, as we talked about when we talked about the introduction to the central nervous system, are the primary ion channels that are mediating neurotransmission, especially down the axon. And so as they open up, you have influx of sodium ions, the cell is depolarizing, and you've got that positive depolarization fluxing down that axonal projection. Here you can also see kind of more of a molecular model of the sodium channel. Again, this is just kind of a cartoon version that we're looking at here. So you can actually see the pore that's created for sodium, as well as here you can see the anesthetic represented in the way that we saw it in the previous slide as it passes through the membrane and then is able to essentially interact with that pore and essentially block up the influx of that sodium into the cell. Okay, so the effects that it has on synaptic transmission, because sodium is no longer able to flux into the cell, it's going to alter synaptic transmission. Not surprisingly, again, we saw this figure prior when we were talking about intro to CNS, and this depolarizing stimulus here, right, that's mediated by the influx of sodium ions. And so if you're blocking that channel, you no longer have that depolarizing stimulus. So the threshold for excitation is essentially going to increase. It's going to require more sodium to influx in order for the threshold to be reached. Your impulse conduction is going to go down. The rise and rate of the action potential is going to decrease. Again, you've got fewer sodium ions fluxing in. The action potential amplitude is going to decrease as well. And eventually the ability to generate an action potential is no longer a possibility. So here you can see in this case, what we were looking at is a recording of a single cell with repeated stimulation. And so upon repeated stimulation, you see over time, as that cell undergoes more stimulation, the block of the synaptic activity decreases over time. And you can see that as a function of the amplitude of this sodium current. So over time, that sodium current gets smaller and smaller and smaller because you've got more of that of those local anesthetics coming in and blocking that pore. So it's almost an activity dependent type of blocks, meaning that the more active a neuron is, the faster that the particular anesthetic is going to have that effect in action because it's gaining access to that sodium channel more rapidly. Any questions about the effects on synaptic transmission? Okay. So kind of as a reflection of that, you can see that there are different types of nerve fibers that are essentially differentially affected. So essentially the more active nerve fibers might be affected more quickly. And so when we look at fiber types here, you can see in this table, you know, your type A fiber types, your type B and type C. Type A, your alpha, beta, gamma, and deltas. Again, they're going to have different functions in the sensory system, as you can see reflected here, as well as their different characteristics in terms of diameter and myelination. Interestingly, you can notice their conduction velocity as well. And then what's nice about, I think, this particular table is it shows you the sensitivity to block. And so here your pain and temperature delta fibers type A are going to be far more sensitive to block than your proprioception and motor, your motor cells. Type C, obviously, are dorsal root, pain, and postganglionic. And then you can see those are going to have high sensitivity to block as well. So again, it's just interesting to note the differences and susceptibility of these different fiber types to this sodium channel block. And often it is, again, a reflection of the activity of those specific cells.
So does that correlate with the myelination? Because it looks like the least myelinated have the more sensitivity to the block. Is that a correlation or a causation?
I would say that's probably more of a correlation between the two. So again, as you have that lighter myelinated, you have probably easier access to those sodium channels. Those heavier myelinated are still going to have sodium channels that are distributed at those nodes of Ranvier. And so that's where you're going to get the site of action of the local anesthetic on those heavier myelinated cells.
Okay, thank you.
Mm-hmm. Wow, that's a Bonnie, that's a great question, and I'm going to look it up as an introduction to tomorrow's lecture. Okay, we've got maybe a minute here. I'm just going to, I guess, leave you with this really quick. There are variables that affect the action of these local anesthetics, and so things like pH and vasoconstrictors. I do want to make sure I spend some time on this slide kind of walking you through this, because I think this is a very important point. Things that can affect the effectiveness of the local anesthetics, and then kind of the co-treatment with vasoconstrictors, I think is an important point, because it does have some clinical implications too, as to dosage and how there are some negative reactions sometimes to local anesthetics. And I think vasoconstrictors, or the use of a vasoconstrictor, can exacerbate that in some instances. So I'm going to pause. We've got a minute left here in class, and I just want to see if anybody has any additional questions, again, about this topic that we're talking about now, about class as a whole, questions for myself or for Dr. Parker. And like I said, you guys have been great about asking questions during class today. Okay, so the question I didn't answer that I missed here, a high sensitivity block, does that mean it is easy to block or harder to block? A high sensitivity means that it is it's sensitive to a lower concentration of block, so it's, I guess, in a way kind of easier to block. So a high sensitivity means if it has a high sensitivity versus a low sensitivity, if you treat them with the same concentration, your high sensitivity fiber is going to be blocked versus your low sensitivity fiber, if that makes sense. So great question. But does anybody have anything else? Yes. Okay, well, if that's nobody has any questions that they'd like to pose, I'm going to make sure that I've updated these slides as soon as we finish wrapping, kind of close everything down here with our session. I look forward to meeting with you tomorrow morning, going over local anesthetics. I'll update the study guide. I'll also re-update that to Moodle. If you have any questions or concerns, feel free to reach out via Moodle. And then I'm also happy to individually Zoom with you as you're studying if you have any questions as well. So hope everybody has a great day. If Dr. Parker has any final announcements, then I think do you, Dr. Parker?
No, I think we're good to go.
Okay, great. I hope everyone has a wonderful day, and thank you so much for your time. Keith, if you don't mind sticking around, I actually have a quick conversation with you too. Like,
Yeah, I'll just stay right here.
okay.
Hey, Katie, I felt weird because it's still recording, but that's okay.
Oh, I
So
can, just a second, let me stop.